Hello, everyone. Thanks for joining today's session of the Research Ethics and Policy series. My name is Holly Fernandez-Lynch. I'm an assistant professor of medical ethics in the Department of Medical Ethics and Health Policy at the Perelman School of Medicine, and I co-host the REPS series along with Steve Jaffe. Today, we're really excited to hear from Dr. Haresh Kirpalani, and he will be discussing balancing ethics and the need for evidence in his SAIL randomized controlled trial, which examines sustained aeration in the lungs of premature newborns. And then after Dr. Kirpalani's presentation, Dr. Chris Feudtner will provide further ethics commentary. We'll hear again briefly from Dr. Kirpalani, and then we'll open things up for questions. And I'll just have a couple of quick announcements before we begin. Actually, Mary, just remind me, oh good, I do see that this is recording, and so we wanted to flag for everybody that the REPS sessions are recorded, and we post the videos to the Medical Ethics and Health Policy website soon after the sessions take place. And you can see on this slide the full 2021 schedule of REPS speakers is available, and you can find out more about the topics that each speaker will be covering at our website, which Mary will put into the chat. I also wanted to flag here that we have a long list of potential speakers that we're considering for next year and beyond, but we'd also be interested in your suggestions, especially if you are thinking of individuals from diverse backgrounds or who could contribute diverse perspectives to issues relevant to research ethics and policy. So please send any suggestions my way. Next slide, Mary. And just a couple of reminders about some resources available from our department. We continue to populate some online resources, kind of webinar type videos on ethics, policy, and COVID-19. And you can see some of the topics that we have available on the screen. Next. And then we also have a series of short research ethics courses available for free continuing education credit. And Mary will post the link to both of those sets of resources in the chat. Next slide. And then finally, a sincere thank you to our co-sponsors who help make REPS possible, along with Mary Pham for her wonderful administrative support. Next. And now it's my pleasure to introduce today's speakers. As I mentioned, we're joined by Dr. Haresh Kirpalani, who is the Emeritus Professor on the Pediatrics faculty, both at the Children's Hospital of Philadelphia, as well as McMaster University in Canada. He's a neonatologist whose work emphasizes randomized trial evaluation of common therapies in newborn and pediatric ICU medicine. There's a lot more that I could go on to say about Dr. Kirpalani, but we'll just point you to lots of information that you can find about our speakers on the web. And then, as I mentioned, we'll also hear from a respondent, Dr. Chris Feudtner, who is a pediatrician, clinical investigator, and ethicist at CHOP and Penn, who focuses on improving the lives of children with complex chronic conditions and their families. Well, we're really excited to hear from you both today. Thank you for joining us. And as a reminder, for those of you who are tuning in, we'll have about 15 minutes for Q&A at the end. So if you'd like to post any questions as we go in the chat, I will keep tally of those and ask them to our speakers. All right, Dr. Kirpalani, the floor is yours.
Okay, good morning. Can you see my slides okay?
Yes, you're all set.
Okay, well, good morning, everyone. I'd like to very much thank Holly for this kind invitation. I'm sorry that I can't be there owing to COVID. I'm especially fond of Philly in pear blossom time, and it's a long time since I've actually seen CHOP or my friends at CHOP, but there we go. Nonetheless, the subject of this talk is the newborn, although hopefully without Da Vinci's radical cesarean section, as he shows. I want to disclose, obviously, that my only source for disclosure is that I'm the PI of the SAIL trial. So you'll have to take everything I say with a truckload of salt. The objectives we're going to cover in about 25 minutes are listed out here. I'll be very light on the biology of the background, but I'll essentially show that in one slide. But the bulk of what I'll talk about is what I think you're most interested in, is our approach to the informed consent procedure and our request for an IRB approval for deferred consent. And I'll focus on 3 points, which I'll elaborate on: the poor prediction of an ultimate delivery in preterm labor presentation, a selection bias with antenatal consent procedures, and the emergent presentation of many preterm births. With that, I'll pass to the results of the SAIL trial in brief, and highlight some of the international neonatal community responses to SAIL, because it was a little bit controversial. And then I'll close with just 3 or 4 slides on some international regulation wordings and parent views as a segue into Chris's overview. So first of all, what was the rationale of the trial? Well, worldwide, the delivery room, or the DR, remains a dangerous place indeed. In the under-resourced world, it's the place where most children die worldwide. It's the place which Clement Smith called many years ago as the shadow of the valley of birth. It's because the infant is passing from a passive respiration, where she is getting her oxygen from her mother, to an independent active breathing, where she's opening her lungs, and this is a fraught maneuver. In more developed countries, clearly that's less of an issue for death in the delivery room. However, it's still a problem, particularly for preterms. And moreover, for preterms, there remains long-term cognitive and cerebral palsy outcomes, which are deleterious. And they are often foreshadowed by bronchopulmonary dysplasia, BPD, which is, I would say, set up often in the delivery room. And at the stage that we were beginning to think about this, opening the lung at birth by this maneuver of sustained aeration was fast becoming an accepted standard in several parts of the world, despite a few rather small inadequate trials, inadequate by my view. And we were further informed of the paucity of an evidence base. This is an overview of the recommendations in the 2010 International Liaison for Committee on Resuscitation recommendations for neonatal resuscitation. And I think you can see that only a quarter are either RCTs or meta-analyses driven, or studies that were concurrent controls. I would warrant it hasn't changed that much since then. Yet there was caution being expressed by ILCOR about this new technology of sustained aeration, and they really called for further studies. We set out to evaluate this using this PCOT format in a population of 23 to 27 weeks. Does a randomized intervention of sustained inflation aeration. I'll also use the term SI, plus CPAP, as compared to standard resuscitation or neonatal resuscitation program, NRP, result in the lowering of the primary outcome of BPD or death by 36 weeks. Now, apart from the 23 to 26 plus 6 days, in other words, 27 weeks gestational age inclusion criteria, we had another rather narrow window to assess eligibility. And that was that we didn't want to throw this at every preterm less than 27 weeks, but those most at risk, in other words, those that required resuscitation due to an inadequate respiratory effort, defined here by the NRP algorithm. And that again narrowed the eligibility window. Passing to the ethical considerations, delivery room research typically is prospective using an antenatal consent procedure. Obviously, if we're talking about newborns, we're talking about a surrogate procedure, obtaining that consent from parents or their legal guardians. It's challenging to get a prospective consent around the time of preterm birth. They really entail three separate challenges which all come together. There's a limitation of time. The mother is undergoing a compound of various grades of physical and emotional distress. And the consent procedure is further vitiated during active labor with pain medication, possible absence of partners, and possibly a reduced ability to process information. So we did request of the IRB, and we were the lead site at UPenn. So the primary site for the whole trial in regards to the consent procedure was the UPenn IRB. And I'll go through now a little bit of why we requested that. There are essentially three reasons. First of all, there's a poor prediction of mothers who present in preterm labor as to whether in reality they actually will deliver in a certain preterm window. And related to that, on the other hand, there are some mothers who have a very fast progress to delivery. This was particularly highlighted in one particular study, but in general in the NRN Neonatal Research Network of the NIH collaboration, NICHD, in their trials, between 4 to 5 mothers were consented in an antenatal consent procedure for every one infant able to be recruited. Thus, 3 to 4 mothers did not deliver within the eligibility of the gestation provided, but nearer to term. The corollary directly is that hence 3 to 4 women underwent consent discussions, presumably already facing considerable stresses of preterm labor. And as I've alluded to, some women were not approached as delivery was too rapid to approach them. We'll get into a little more numbers in a short while using the SAIL study. All of that, again, had further knock-on effects. And the second reason that we asked for consideration for a deferred approach was that a selection bias is possible with prospective antenatal consent. This was particularly highlighted in the support trial. Even non-neonatologists have become familiar with the support trial due to the notoriety it achieved, but I'm here focusing on one other aspect of that. That notoriety rather drowned out the whole issue being highlighted in this particular slide, and that is that enrolled versus non-enrolled infants in that study appeared to have a better baseline of risk markers, including those that have asterisk in red, race, maternal education, insurance for healthcare, particularly important in the US, obviously, more antenatal steroid. Now that's something you may not be familiar with, but that is a marker for better outcomes, because randomized trials have now very convincingly shown from the 70s onwards that if the infant has antenatal steroid as a fetus, he or she will have a better outcome. The third issue that we put to the IRB to consider a deferred approach was the issue of the very narrow window of eligibility. I don't propose to take you through this complicated diagram on the right. I want you to focus on the left-hand side of this slide, where the recommendations for how long a baby should be assessed before receiving any resuscitation is emphasized. The time frame is, I think you will agree, rather short. Within 30 seconds of delivery, you've got to make a decision according to the NRP, our standard guideline, as to whether or not to initiate resuscitation and how. This is the eligibility timeframe of the trial that we were considering. Naturally, you're going to ask, was there any consideration of a quotes minimal risk? Well, the main risk is pneumothorax, a condition of extrusion of air into the thoracic cavity or the chest, which compresses the lung, impeding the ability of the lung to open. The problem is that that's present in both experimental procedure, sustained inflation, and we argued in standard resuscitation. The available meta-analyses at that time did not appear to show any excess in the SI procedure. Furthermore, pneumothorax was understood to be a known risk of any newborn resuscitation. Furthermore, all caregivers that were involved in certainly this trial in the US, Canada, Europe, or Australia had to have completed a certification in the NRP course. Finally, I've alluded to this before, but in many European sites, SI was already being considered a standard of care. In the event, the IRB rejected a deferred approach, and many sites who had already wanted to join the SAIL trial deferred to that viewpoint. We had 18 centers in 9 countries recruiting. 12 used prospective antenatal consent, including all the USA sites. None of the USA sites made the decision by themselves, but deferred to the IRB of record. There were 6 sites who did adopt a deferred consent, that being understood as being one where the consent was sought as soon as the mother's condition allowed after delivery. Of those, 4 used a combination of antenatal consent, and deferred consent was permitted by the IRB in situations where time did not allow antenatal consent procedures. Again, of these 6, only 2 would use exclusively a deferred consent. One was in Canada and one was in Austria. In the event, let's look at the results. The trial was stopped early for harm. At the 4th DSMB review, 415 infants had been evaluated from a total calculated sample size using standard alpha and betas of 600. Now, I'm going to take you through the next 3 slides in portions of the consort diagram. It's rather difficult to walk through in a slide, so I've broken it up. And what I'd like you to concentrate on here is in the antenatal consent procedure. I'm going to walk through the pre-consent exclusions on the top. There were about 1,000 who were excluded, about almost 700 excluded prior to consent. Of those, about 100 could not be approached as delivery was imminent and precipitous. That's a fair chunk. Next, we move on to those who consented. and were excluded. That was about just under 700 and just over 300 became ineligible. This is the predictive issue that I was talking about. For whatever reason, the biology not being fully understood, at least as far as I understand it to this point, obstetricians are not really able to tell precisely who will switch off and who will not, and thereby go from preterm labor through to extended gestation. In the event, we had an enrollment and we could report on 426 infants, but probably of more interest to you is that broken up. This is a very busy slide. Please focus just on the bottom, which partitions out those babies who had received an antenatal consent, those babies who had deferred an antenatal consent, and lastly, the deferred. And I just want to draw your attention to the last bit. So of those deferred, there were about 200, 225 who were randomized, and 30 odd, 34 later on, those parents refused a consent. Now, when you look at the results of the SAIL trial by arm of consent, we performed that as a post hoc. Well, actually, it wasn't post hoc really. It was a secondary analysis. There were some minor differences, but nothing that achieved statistically significance. But this here now is just looking at the demographics overall of the SAIL trial by consented group. So here's deferred and antenatal, and you can see that in the deferred group, so a total of about 230 versus just under 200 in the antenatal consent, there were indeed more infants who presumably were at more risk because they had less complete antenatal corticosteroids. So the primary outcome was death or BPD and showed no statistically significant difference. I'm here now just talking about the adverse outcomes and what drove the early stopping of the trial. We had a list of a priori secondary outcomes that we were going to monitor very closely because we also did not want to undergo a situation where we perpetuated a trial with early outcomes of harm immediately following the delivery room events. And death certainly was the only one that was statistically significantly different and favored the NRP or standard arm. You'll notice that I've highlighted by red at the bottom the risk difference adjustment for a number of markers, including consent type. The reason I alluded to the somewhat controversial nature of the primary outcome is shown here. This is a post hoc Kaplan-Meier as part of a futility analysis. You can see that we certainly had divergence of the two arms in the first week of life, achieving statistical significance, worryingly so. But by 36 weeks, they had come together and the P was 0.11 for the whole curve. We did do Bayesian analysis. That's beyond my ability to concisely comment on, but I think you can just take it as read that our statisticians were pretty clear that had we continued to full enrollment, we would have been most improbable to find a difference in the primary outcome. The neonatal community response is shown here, the consensus guidelines that were drawn up in Europe, which had been one of the main loci where sustained inflation was considered a norm and a standard of care, said that the results were disappointing, and that until further analysis, SI should only be used in clinical trials, and that was in the consensus guidelines very shortly after we reported, and certainly I think has changed practice. The early stopping is of course subject to a slight bias that was reported by Gordon Guyot's group long ago from McMaster. A form of external validation can be seen here. This is a later, much more complete meta-analysis performed by Liz Foglia. And for the primary outcome of that meta-analysis, all deaths to 36 weeks, just equivocal crossing over the boundary, but for the secondary outcome of death's first 2 days of life, unequivocal difference, sort of confirming that what we found was likely true. Now, just as a segue to Chris, this is some points about the background on deferred consent. This is not a new debate. I'm sure members of the audience understand this far better than me, but it's traceable to the 1980s. There are certainly divergences in the regulations between different countries. I would say that what little we know, parental responses are certainly not negative in several jurisdictions. This comes from Pennsylvania, actually, from Baltimore, 1986, during a study of thiopental in adults who were comatose, where the group proposed a deferred consent in critical emergent situations. When you look at the regulations, I don't propose to take you through this rather complicated and somewhat daunting slide comparing the various regulatory bylines in some countries. I've just boxed in as a segue for Chris, who will talk more about this, about the wordings and perceptions of risk. At a glance, you can see that those wordings certainly differ. There have been in jurisdictions some examinations of parents' views about this. This is from Australia, the relatively small sample sizes, of course, in the deferred consent, 100 parents, 50 in the prospective consent. More parents sort of suggesting this is to help future babies that they consisted. Their consent arose from. It reminds me of the gift of altruism identified in blood donations by Richard Titmuss in the 70s. And similarly, this is a very small study out of San Diego where the IRB in this particular hospital granted a deferred consent for 2 accepted means of clamping the cord. Retrospectively, the investigators asked parents what they thought about it, and how, what I've boxed in is, how do you feel about your baby's participation? Parents were either neutral, positive, or in a third, strongly positive. Again, redolent a little bit that parents are perhaps open to helping future generations. I think we don't know enough about parents' viewpoints, and perhaps we need something along the lines of an Oregon type study, and the whole notion of participatory democracy and the perspectives there, I think we're only beginning to touch upon in medicine in general, and even less in this arena for sure. In lieu of a conclusion, before passing to Chris, I think it behoves one to just recognize that at least we're not doing harm. This is Liz Foglia's overview of several randomized trials in the NRN, the Neonatal Research Network, where she examined the primary outcome of 2 years, outcome of death or major morbidity between those who were eligible but not enrolled and those who were enrolled. Contrary to the hoo-ha raised by Public Citizen, we appear not to be at least doing harm. I thank you for your attention. Chris, I'm going to stop sharing slides here.
Okay, Haresh, thank you very much. And I am going to share slides. So I want to follow up on really the very high level and yet very detailed view that Haresh gave you of many aspects of his study. Before I do, I need to offer a disclaimer. I am not, and I don't want to pose to be an expert in clinical research ethics. I'm not an IRB member. I certainly don't head an IRB, so do not take anything that I'm about to say as IRB or even research ethics gospel. My personal view is that this SAIL trial was conducted in an entirely ethically appropriate manner. I know that people could disagree about that, but I'm just disclosing that. And to me, it also underscores the importance of doing these kind of studies, these comparative effectiveness studies, which beyond even the issue of waived or deferred consent, the whole concept of doing comparative effectiveness study keeps getting criticized. And yet here we are with an example that really motivates the importance of doing them. And my goal in this short commentary is to think through why we, members of this audience, or more broadly, would have differing judgments about the waiving of a consent, deferred being a particular variation on a waiver, for comparative effectiveness trials in the US context. As Haresh showed, and we know the context would be quite different in other countries with other regulatory apparatus. I want to thank, before I go further, John Merz, who shared with me an article that he has forthcoming on essentially the historical overview of waivers of informed consent for research in the US context in particular. And it helped me to pull together some of the thoughts that I had rumbling around less organized in my head. And I guess, of course, what I have to say is my responsibility, not theirs. So what are the ethical criteria that people who are tuning in who may not think about this a lot in the US context for a waiver? And there are at least 4, maybe people could read the regulation and find other ones. And I'm going to walk through the minimal risk issue that Haresh pointed to, importance of the research criteria, whether it is impossible or impractical to obtain consent, and whether obtaining consent would somehow invalidate the study results due to introducing some kind of bias. Now, I can say that, but what do these mean? How do these criteria actually interrelate? And then back to the regulatory language, what does it actually mean if you're going to try to operationalize any of these criteria? So the invalidity, I'm going to go in reverse order because I think they flow a little bit better that way. The basic concept is that if the process of obtaining informed consent would create a bias one of 2 ways, either who actually joins the study and agrees to participate versus who does not is, and Haresh already pointed to some data, and it's all over the place. We know this, that the people who enroll in trials and the people who do not look the same. Now, how different they look and whether you can account for it with adjustment, but there is a potential for bias there, we know that, which makes the inference for external generalization of the findings. The study is valid, but external generalizability may not be. It could also affect how they might participate in the study. That's not really relevant here, but there are certain types of studies where there's a thought that if you go through informed consent, it will change behavior. The key point in this by regulatory language is that it would destroy or invalidate the research. If we do research and we can't trust the findings, it's pretty much not worth having done it, because what have we learned? We can't believe it. So destroy or invalidate, strong language, meaning it basically deteriorates the internal or external validity. Now down at the bottom, that's not a binary outcome. There's a degree of degrading, Every study has a little bit of risk of bias, and as you get more, at what point do you cross a threshold and say, we can't do this, it would destroy or invalidate the research? That is one point where reasonable people could draw that line differently. Second, what does it mean for it to be impossible or simply impractical to obtain consent, which is one of the guidance that is given. It is particularly sort of obvious, maybe, for very large scale population-based studies where literally maybe thousands, hundreds of thousands of people and their data, maybe even prospectively, are going to be used. Running around and actually trying to obtain informed consent on that number of people in a time frame is at least impractical, if not downright impossible. But as you hear what Haresh actually just outlined, does the difficulties of obtaining consent and the inefficiencies and the cost on people who are consented but then cannot participate, does that rise to the standard of impossible? Or is it just simply another consideration? Is one of the things where I think reasonable people will hear that language and think of different thoughts and come to different conclusions. Waivers of consent are or deferred, but typically deferred is not used in the US. Waivers of consent might be used in a variety of settings for trauma, and basically where that 30 seconds that Haresh talked about is all, you were perfectly healthy 30 seconds ago, and then you were hit by the bus, and now they're gonna have to do resuscitation in the field. There's no opportunity. How does that figure when maybe we could have done some consent before, but it becomes very inefficient and it may be impractical to the degree that it is unwarranted? The importance criteria, this really starts to become even more judgmental, that the objectives of doing the research are of immediate importance, again, according to the regulatory language. Well, what counts as important? Clearly, the nature of the outcome, preventing death, is, most people would agree, but not everybody, more important than preventing temporarily bothersome symptoms. One of the things I can say as a clinical ethicist, which I am, is that the problems that Haresh talked about with this bronchopulmonary dysplasia are lifelong, horribly difficult for the babies as they grow into adulthood if they have severe BPD, and their families. That certainly is an important health problem if you have it, on par with having cancer or having other terrible diseases that will alter your life. What about, and this is not part of SAIL, healthcare associated costs or other costs, where people are trying to say that studies that are looking at making the system more efficient or costs to be lower, is that sufficiently important to waive consent? I'm not arguing it is, I'm just saying I've heard arguments that that has become at a societal level so important to us to control costs and expenditures. Very expensive drug versus an equivalent that is literally 100-fold or more less expensive may be sufficiently important. The second aspect of importance is, well, how big an effect is your intervention going to have? The problem is huge, but if you're going to make virtually no difference in the outcome, yeah, you've got an important problem and a teeny-weeny solution. So maybe that's not important research unless you can have hope or an expectation that it's going to budge the outcome to a significant size. The problem with that is that sometimes progress is not made immediately, but incrementally over time. And if you look at what has gone on in neonatal care, there have been some truly revolutionary interventions like surfactant, the medication that is put down into the lung and helps those lungs expand. That was a game changer, but not a full cure. It just radically altered things. Many of the other improvements that have made it more likely to survive at early and earlier gestational ages have been incremental, but they sum up. So any one of them may make a 2 or 4% difference, but you do that several times and you compound that improvement. And next thing you know, you have quite a big difference in the outcomes. So this problem of judging importance is not only things we've highlighted, but are you enabling a ladder or a staircase of improvement to occur, and counting on over the next 10 years, there'll be 3 improvements, which will be a sizable improvement. If we say each of the steps have to be a big improvement, we will never get the staircase. The last area I want to focus on is the difficulties we have thinking about risk. People who do clinical epidemiologic training and courses spend an inordinate amount of time being taught how to think about risk. It turns out to be subtle in certain ways, and the language that we use sort of in our day-to-day life often lumps a lot of things together, which are best thought of as being pulled apart. And in both the support trial, which Haresh referred to, which both he and I have a different set of reservations about than anything that we're talking about with SAIL. It just is a whole nother kettle of fish, but it is similar in terms of comparative effectiveness. And that characteristic means that you have to start to think about whether the risk, what are we talking about? The language is that it has to not adversely affect the rights and welfare of subjects. So thus the minimal risk standard can be thought of. One is the risk really, really low in both arms of the study? So low that you barely can see it. If we were talking about risk of death, it's like 1 in 1,000 and 1.3 in 1,000. Okay, it's just so low you can't even notice it. Or, and again, the epidemiologists, this is not like a shell game of playing games here. Unfortunately, the babies that Haresh is looking at in the SAIL trial actually had a fairly high mortality. Are we talking about that absolute value or the relative difference or the absolute difference, what we might think of as the marginal difference between the 2 risk groups? Or are we thinking about that marginal difference between being in the trial in either of the arms and not being in the trial? Because there have been, particularly in neonatal research, some evidence of potentially a trial inclusion benefit, which may have more to do with who enrolls and who does not enroll, or being under a strict protocol of care. I happen to be more of the mindset that we are talking about here, the marginal risk, not the absolute risk. And certainly the marginal risk between the 2 groups in this setting suggests that the difference of being in either arm A or arm B is very, very equivalent. And as Haresh showed, all of the outcomes, depending on what you care the most about, including survival at the main outcome, there was no statistically significant difference in survival. So as we start to think about all of this, and we use the term risk in many, many different ways, how we communicate to each other, how we think about it in our own mind, we use this in different meanings. And we've tried to unpack, again, with the support trial, the very different ways that people actually talk about risk. And there were at least 9 different ways that people were using the phrase risk. And each of them had different technical ways you might think about specifying it and connotations that go along with it. And my point here isn't that there is definitely a right way and I'm right and everybody else is wrong, but we are in a Tower of Babel situation if we don't realize that we think we're saying the same thing, but we're actually pointing to quite different things. So in summary, these are the criteria that we should be thinking about with regard to a potential waiver of consent. And whether you think this should have been applied, it was not applied in the US setting, and it was not applied even in most of the other settings, but it did wind up being used for quite a few of the children who were enrolled. These are the criteria in the US setting, which is not where it happened, that we should be thinking of. How do we actually talk about this as we try to learn from SAIL and other studies about how to apply or not apply waivers? These are the criteria that we should be thinking about, but even more, how do we get clear as to what we mean when we talk about these issues? All right, I am going to stop sharing my screen.
Great, and Haresh, did you want to have a few minutes to respond?
literally just one minute, actually. So thank you very much, Chris. Just a minor thing to just clarify. So the issue about 50% of preterm labor women who don't go on to deliver within their window is, I certainly don't stress the cost aspects of it and the inefficiency, although they're there. What I'm stressing actually is that 50% of the women thereby underwent a troubling, perhaps, consent procedure at a very, very difficult time. Thanks.
And I hear you loud and clear on that. If they don't enroll, or they actually wind up enrolling, but they don't actually wind up getting enrolled because of eligibility, so they consented, but they're sort of in this gray zone. And again, this is where I'm probably going to get in trouble as not doing research ethics, that there is, for all participants, what you're saying is that that path involves harm without prospect of benefit because they actually never even got to participate in the study. The benefit, the altruistic benefit of having participated.
Great. Well, thank you both. And I want just to remind everyone who's listening in, you're welcome to post questions in the chat, or if you'd like to raise your hand, Mary has put the instructions for how to do that, and we'll allow you to unmute yourself and ask your question directly. But let me kick things off with a question for Dr. Kirpalani, which is whether and what the discussion amongst your study team looked like when you were contemplating different approaches to consent, depending on the country that a participant was living in, right? So, you know, the option might have been there to kind of have the whatever jurisdiction had the highest bar for consent to apply that across all participants. So for example, you know, if the US doesn't permit deferred consent, to just treat everyone in the study the same, and whether you think, I know you haven't studied this empirically, but what your impression would be if participants learned that, you know, others were asked explicitly to be in the study in advance rather than deferred consent.
Yes, thank you for that. So this wasn't the first time in our neonatal community of delivery room researchers that this has been broached. And in fact, perhaps one could say that the Dutch and the Australian participants in the trial had long been doing, long meaning relatively, a year, a couple of years, trials in the delivery room with a deferred consent approach. We certainly discussed with all of the sites what was happening at the IRB of record, because that was what was driving each of the sites, and the funding was coming from NIH. So the ground zero, if you will, was what we were experiencing and discussing with the IRB at UPenn. So we were having these discussions. I think it would have been well nigh impossible for some sites to have joined the study if they were told that this would have to be an antenatal consent procedure, particularly since some of these sites were actually long familiar with the practice of sustained inflation, which in this context goes back about 10 years or so, 10 years before the SAIL study was actually done. One could argue that the study was done too late, should have been done much earlier, but that's another matter. They had already adopted it as their standard of care. So I don't think it would have been feasible.
And can I interject? Holly, you used the phrase the highest bar, and I think that that's actually a little bit what's under debate here. I think you could have used the term the most demanding prospective standard of consent, but I think that we should be careful about saying what is the appropriate highest bar standard for conducting this kind of research. Haresh, if you had not had any deferred consent participants because it had not been allowed, it looks like enrollment would have been substantially less given the numbers that enrolled that route.
Yeah, that's absolutely true. I wasn't going to particularly flag that, although I gave the numbers, but it's absolutely true. But the more weighty consideration, certainly for me, is the generalizability, the external validity. There's another point to this. We've talked about the 50% in the preterm labor who age out as they do not go into preterm labor. But there's also those mothers who undergo precipitate delivery and who are not going to be ever, at least in the way we practice right now, captured in any research procedure in this nature. And we know that there are a very, very different set of mothers and thus very, very different set of babies from mothers and their babies who are sitting in a ward having their preterm labor hopefully switched off.
So do you believe that the hybrid model is the best model? Unless somebody starts asking questions, I'm just gonna ask.
We do have some questions, Chris, but so Haresh, why don't you answer that one? And then I've got Susan Ellenberg, Steve Jaffe, and John Mertz in the queue.
Personally, I think a hybrid model, according to what that societal norm might be and has been accepted in that norm, I can't prove to you that all Australians think that this is a good idea or that all Dutch people think that this is a good idea, but I think that they've got some sense of their community norm. I'm not sure what our community norm, I'm not in the US any longer, but what our norm in the US might or might not be. Thank you.
Great, Susan.
Okay, thanks, Holly. So the phrase deferred consent was used a lot in the, I guess, the 1980s and early 1990s for emergency research settings where it was difficult to impossible to actually get consent either from the patient themselves who were, unconscious, or a proxy because of the time frame. And in the mid 90s, the NIH and the FDA sort of got together and felt that deferred consent was not a viable concept and developed a regulation that was issued, I think in 1996 or 1997, for exception from informed consent. Now, one of the conditions there is that it was impossible basically to get consent, a prospective consent. That's not really the case with this study. The case with this study is seemed like it was felt to be too burdensome to the parents to try and get consent in this very fraught situation. So I would just offer one example, which was a different kind of lack of consent. It wasn't deferred consent. It was not consent at all. That was the Zelen design, where you didn't get consent from people who were being treated in what was considered the standard of care way. And that was used for the ECMO study that was done at the at Harvard in I guess the late 80s or early 90s, because it was felt that for parents whose children were thought to have had only a 20% chance of survival, and they thought ECMO was going to bring it to an 80%, how could you even ask them? How could you tell them that their baby only had, they were going to have a 50% chance to get this, that might actually have their baby survive? But so they used that approach. In the UK, a similar study was done of ECMO where they used the prospective consent, and it worked out fine. The parents were willing to give consent. They were approachable. In fact, there was a paper written afterwards where they discussed with some of the parents who participated how they felt about the consent procedure. So just to say that, this wouldn't have been, I don't think this would have been eligible for the exception from informed consent because it was not clearly impossible to get consent from the parents. But I just wonder about the assumption that it would have been too hard for parents to give consent.
Thank you very much, Susan. First of all, as regards the Zealand design for the ECMO study, it was halted after about 5 or 6 babies. I think it went on for a total of about 12 babies. And it was very problematic in the neonatal community as to how much we could.
That was the first one. The second one, and the one done at Harvard, was not. That was the one at the University of Minnesota that you're talking about. But the second one was also done with a Zealand design at Harvard.
And I mean, even following then, it did take quite a while for the community to understand the implications of the ECMO panoply, and it followed from the Leicester trial in England, as you're talking about. So it was possible. But what you've done here is to contrast the impossibility versus the burdensomeness. And I totally agree that there's a difference. In response to Chris's remarks, pointed out that there was actually a group of women here who go into preterm labor with whom it's really, I think, impossible to engage in an antenatal informed consent manner because of the pace of their delivery. So actually, that counterposition, I think, both sets of women would be actually need to be considered. Those that truly it is impossible, and those that, as you put it, are too burdensome.
So we just have a couple of minutes left, and I want to get to a few more questions. So John Mertz, are you able to unmute yourself?
Hello.
Yeah. Well, thank you. Thanks for that interesting talk. I could launch a broadside against this in lots of different ways, and I would like to basically build a little bit on what Susan said. And the issue that was raised by her and by the ECMO trial was that there was a strong preference in the patient population for one treatment or not. And at Harvard, they actually had to treat the babies who were getting ECMO on a different floor than the babies who got controls, because they didn't want parents who were not getting ECMO to see the babies getting ECMO. But that really speaks to, and the National Commission spoke to this, Bob Truog's 1999 article about using waivers, not getting consent for clinical trials. He talked about it. And it really turns apart on preferences of subjects. So if it's patient preferences driving a bias, then you don't have a right, from my perspective, and according to the National Commission, Truog's article and the like, to say, well, I'm not going to get your consent because you wouldn't agree. The support trial was biased because 45% of moms said no. Moms were asked on an average of 2 times to participate in the trial, and then 2 moms were asked 11 times to participate in the trial. And still 45% said no. I asked Rich, the author of the article you put up, if he would look at what point, how many times did it take for people to say no, and were they consistent, and basically look at his data in more detail. And he said, that's an interesting question, and disappeared. He didn't care to engage me any longer in that analysis. And of course, has not published anything. So that's one issue that I think needs to be addressed, is that if you have a high percentage refusing, and your refusal rate of moms who were asked or parents who were asked, somewhere in the order of 30%, which is fairly consistent with other clinical trials. Then and I think what the problem is with our approach to waivers is that it underweights the value of people. Sorry, my cat's in the background. It underweights what it is getting consent is predicated upon. Is it a right of people not to be research participants and have research done upon them, or not, right?
So John, let me have a stop here just so that Haresh can respond, given that we're at time.
Have you got a clear question? Perhaps I'm too...
It was just it was really an observation. I mean, in some sense, my concern is that we underweight people's rights to say no. And I guess if I was going to throw anything out for your consideration, it would be, if people, I have another study that looks at whether or not people refuse based on kind of like the informed consent disclosure or not. And it seems to be that people might be making uninformed refusals, and people either trust research or not. And by waiving consent, we give those who do not trust research, we take away their ability to protect themselves. So I'll stop there.
Well, I mean, on your central point, I don't disagree. I think we do have to let parents have a choice. And what I stressed was the aspect of the word deferred rather than waive. I'll point out that we did have people refusing that deferred consent. Their data was not used and respected. Their views were respected. I also made the point, although space and time did not allow me to go further into the issue of getting a true societal perspective about the issue about what research, how research should be conducted, should operate.
Well, thank you for that. I wish that we could continue the conversation, and I would invite, those of you who, there were a couple of other questions in the chat, to continue the conversation via email. But we thank you all for joining, and I just want to be respectful of everyone's time and let you go on time. So thank you, Dr. Kirpalani and Dr. Feudtner, for raising these really interesting questions. One example of the challenges associated with obtaining consent in really difficult circumstances. Thanks, everyone.
Thanks.
Thank you.
Bye-bye.